Good afternoon. Welcome to our talk today on drug therapies and ALS. You can please put any questions that you have in the Q&A, and they'll be addressed at the end. We are delighted that Dr. Erin Manning is joining us today to give this presentation, which is so important. Dr. Erin Manning is an assistant attending neurologist at the Hospital for Special Surgery in New York City. She specializes in the treatment of neuromuscular disorders, including ALS, neuropathy, myopathy, spine disorders, and autoimmune disease and sports neurology. She performs nerve conduction studies and needle EMGs for neuromuscular patients. Her research interests include neuromuscular disease and sports neurology. Dr. Manning received her medical degree from the University of Florida College of Medicine. She completed her medical internship at Case Western University Hospital in Cleveland, Ohio, and her neurology residency at Mount Sinai Hospital in New York, New York. She completed 1 year of fellowship in neuromuscular medicine and a 2nd year of fellowship in neuromuscular medicine and sports neurology, both at Hospital for Special Surgery in New York. She is board certified in neurology and neuromuscular medicine. Welcome, Dr. Manning.
Thank you so much for having me and inviting me to give this talk. My presentation. Okay. Okay, so I'm going to be talking about medications used in ALS today. So I'm going to start off with a little bit of just general information on ALS. I'm not going to spend a long time on this. So basically, amyotrophic lateral sclerosis is a type of motor neuron disease that affects motor nerves in the brain and spinal cord. The incidence is 1.8 per 100,000 in women and 2.1 per 100,000 in men. The average age of onset is 60, but this can vary widely. It is less common over the age of 80. The familial or hereditary cases are about 10 to 20%, with the most common genes being C9orf72 and SOD1. Survival averages 3 years, but this can vary widely and can be extended through things like mechanical ventilation or breathing tube. Some of the symptoms of ALS, 60% of patients are limb onset, meaning that it starts in an arm or a leg, and this is usually asymmetric, so not the same on both sides. 30% are considered bulbar onset, which includes things like dysarthria or slurred speech and dysphagia, trouble swallowing. A primary respiratory onset is rare, but this does occur. Progression is typically linear in that when we use scales like ALS FRS, there's usually a loss in score of about a point per month, but this does not always correlate to the degree of symptoms that patients experience. And the ALS symptoms are a combination of what we call upper motor neuron symptoms, which are things like overactive reflexes, spasticity, or muscle stiffness, and coordination issues and weakness, and also lower motor neuron symptoms, which are weakness, muscle loss or atrophy, and muscle twitching or fasciculations. And these symptoms are progressive. 30% of patients or more can also have dementia or other cognitive issues, usually what we call frontotemporal dementia, which is a little bit of a different type of dementia than the Alzheimer's dementia. That is the most common overall form of dementia. The diagnosis of ALS is made based on the L-Escorial criteria, which combines the clinical evaluation and NCS/EMG findings and divides it into definite, probable, and possible categories. There's no biomarker, so there's no blood test, there's no imaging test that can diagnose ALS. We use to kind of track symptoms and track progression. We use what's called the revised amyotrophic lateral sclerosis functional rating scale, the ALS FRS, and the R is the revised. It's been revised several times. It includes 12 different functions on a scale of 0 to 4. The scoring goes from 0 to 48, with lower scores indicating more functional deficits. So in terms of causes of ALS, the basic answer is we don't know. There's a lot of different pathways that are suspected, which I've highlighted here, and there's a lot of suspicion that it's probably either involving multiple of these pathways or that there may be multiple causes that end up with the same symptoms, and that might be why it's been so difficult to figure out exactly what's causing it, and then secondarily to develop treatments. The hope is continued research is going to lead to treatments that are actually targeting some of these pathways. So in terms of treatments of ALS, so multiple drugs have shown promise in animal models. Then they take those drugs that show promise and they do trials in them. So there's different phases of that. So phase 1 trials are typically safety to make sure that it's a safe drug. And then phase 2 trials are typically small to see if there may be some indication that the drug works. And then phase 3 trials are large trials, and those include a placebo or like essentially a dummy medication. To compare to the medication that's being given. And a lot of drugs have shown promise when they got to those phase 2 clinical trials. Then they went to the phase 3 trials and they failed. And actually a big example of this is Relyvrio. So Relyvrio got approved based on promising phase 2 trials. When they did that phase 3 large trial, it didn't work. And that's why it got taken off the market. So in overall in ALS, in most of these large clinical trials, when they got to phase 3, the patients in the placebo group actually did better. There's been very few drugs actually where the treated group did better than the placebo. So there's basically what it comes down to is right now, there's no cure. There's no drugs that reverse progression. And I'm going to talk about it. There are a couple of drugs that we use that probably slow down progression, but nothing at this point reverses progression. And there are a lot of medications I'm going to discuss that can help symptoms. So there are a lot of symptomatic treatments that we can do. But unfortunately, as of right now, there's no cure. So we divide up the treatments into disease-modifying therapies. So these are medications that prolong survival and slow functional decline, or increase the time to needing tracheostomy or permanent assisted ventilation. And then the second category is the symptomatic treatments. So these treat a specific symptom and is done for comfort and quality of life and can be very valuable in the treatment of patients with ALS. So the disease-modifying treatments. So the first one that was approved was Riluzole in 1995, and I'll talk more about it. There's a few different formulations of it now, so there's more options for patients. A more recent one was Indaravone or Radicava, which was originally approved IV in 2017 and then was approved as an oral formulation in 2022. The next one is Relivrio. So that was originally approved in 2022 and was just basically taken off the market last week. I'm not going to spend a lot of time talking about it, other than saying that patients who are on it, my understanding is the company will allow people to continue if they want to. But I think at most clinics, they're telling people that unless they have a strong reason, that they should probably just stop it at this point because there's no evidence that it is efficacious. It has a clinical effect. The last medication is tofersen or Colosity. That is a medication that was approved in 2023 and is specifically for one type of hereditary ALS for people with SOD1 mutations. And I will definitely be talking more about that in a little bit. So, I'm going to start off by talking about Riluzole. So the mechanism of action, it's a glutamate release inhibitor. This is a medication that is recommended for all ALS patients unless people are having a specific side effect that they wouldn't be able to take it. There's some modest efficacy behind it that is based on 2 studies showing that it delays progression to needing mechanical ventilation and survival is higher after 12 months. So the indications for this are definite or probable ALS. We also actually use it frequently in PLS because unless there's a specific side effect or reason people can't tolerate it, it may provide some benefit. The recommendation is that symptom onset less than 5 years, that the vital capacity is greater than 60%, and there's no tracheotomy. However, as I said, the recommendation is to give it to every ALS patient, regardless of severity, vital capacity, and to give it to tracheostomy patients who are not on a ventilator. There has been some more recent studies that show that there's likely more benefit if the medication is started earlier in the course. However, there's also been evidence that shows that it doesn't slow progression evenly over the entire disease course, is that it seems to delay people go through the same progression in the earlier courses and they spend a longer time in the later ALS stage, rather than it being even and it delays time even in earlier. But as I said before, it does show that there's likely more benefit if it is started earlier. And another more evidence that a longer time taking it is more beneficial is there was a study that showed that there's better prognosis in patients that had a higher total dose, like total cumulative dose over time used. So dosing and side effects. So the medication is dosed at 50 milligrams twice daily. There are actually now 3 different forms of it. So there's a tablet. There is a suspension that can be given through PEG tubes called Tigutek. And there's an orally disintegrating film, Exervan, which is a newer form of it. And so basically it's just like a little square that you put in the mouth and it dissolves. And the metabolism of riluzole may be affected by inhibitors of what's called cytochrome P450 enzyme 1A2. So things like caffeine can decrease the elimination rate. So it's probably best that you're not drinking a lot of caffeine around the time that you're taking this medication, although like 1 cup, it probably isn't going to have a significant effect. The most common side effects are GI, most particularly nausea. And that's often a reason that people end up stopping the medication. The other big category of side effects is effects on the liver, hepatic side effects. So this is why the liver function tests are done with this medication. And other side effects that are less common but do happen, fatigue and dizziness. There are some very rare and serious side effects with this medication, but they are, as I said, in the order of being very rare. So what's called neutropenia, which is a low white blood cell count of a particular type of cell. And this is another reason why blood tests are done for this medication. Anaphylaxis, a serious allergic reaction that's very uncommon, and it can have some effects on the lungs, causing interstitial lung disease or pneumonitis, which is lung inflammation. Those are very rare. And the LFT elevations are very common and occur in up to 50% of patients. They're usually mild, but elevations that are much higher, 3 to 5 times normal, can be seen in 2 to 8% of patients. So this is why we check the LFTs monthly for the first 3 months and then every 3 months. And we usually also check CBC along with that, to look at the white blood cell count and make sure that that is not going low on this medication. So the next medication that I'm going to discuss is edaravone or Radicava. So the mechanism of action of this is that it's what's called a free radical scavenger that may reduce oxidative stress that can build up over time. This is another medication that is suggested for all patients with ALS. There was an initial trial of 206 subjects with ALS that didn't show any benefit on ALS FRS-R scores compared with placebo, but there seemed to be a subgroup that had some more benefit, so they went back and only did another trial where they only enrolled early ALS patients that had an FVC over 80%, disease duration, that should be less than 2 years, and higher ALS FRS scores. And that study was the one that ended up leading to the approval that showed a 33% slower decline in the patients that were on the edaravone. So edaravone dosing and side effects. So there are 2 different formulations of this medication. So the initial one that was approved was a 60 milligram IV infusion that's given over 60 minutes. More recently, there has been a oral suspension approved, which is 105 milligrams or 5 mLs that is and taken in the morning after fasting overnight. So the dosing for both the IV and the oral forms is the same. It's initially done daily for 14 days, then you take 14 days off. After the 14 days off, then you take the medication 10 days over a 14-day period. Then you take another 14 days off, and that's how the medication continues. So basically, you take 10 doses early in the month, and then you do that again next month. So some of the common adverse reactions are things like gait disturbance and headache. Overall, I've seen that those are pretty mild. Usually people do not have significant side effects that actually lead to them needing to stop the medication. That's uncommon. For the IV infusion, some of the adverse reactions are injection site bruising, blood clots, bleeding, and infection. To be fair, I would say that I don't think I've seen anybody since the oral formulation came out. I have not seen anybody on the IV, because the oral is, of course, much easier to use overall. Some rare adverse effects, you can have an allergic reaction, anaphylaxis. Some people can get like a skin hypersensitivity or a bad skin rash to it. And the medication contains sodium bisulfate, and some people can be allergic to sulfates, especially in people with a history of asthma. So it can cause a severe asthmatic reaction in people with a history of asthma. So that would definitely be something to watch out for. So the next medication I'm going to talk about is tofersen. So basically, this is a medication that is used in patients with an SOD1 mutation. So this is where genetic testing in ALS patients is actually now important, because you won't qualify for this medication without the genetic testing. The good news is that there are free options for genetic testing. So this is something that, you should be discussing with your neurologist. If you're in a multidisciplinary clinic, then discuss it with the team there, or discuss it with a geneticist or genetic counselor. And it's important to discuss genetic testing, with your physician, with a genetic counselor, because if you do test positive for any of the genes that can be associated with ALS, that can obviously have some implications outside of you for, outside of the patient, for the family members, for children, for siblings. So, it is not something necessarily to be taken lightly. Even if you can get the testing for free, there are some things to think about. So the SOD1 mutation causes basically an abnormal protein in it. It folds in an abnormal way, and then it essentially starts sticking together, and that seems to lead to the symptoms of ALS. This is 15% of people with familial ALS. And so basically this medication is what's called, it's a gene silencing therapy. So it uses what's called an antisense oligonucleotide. And it binds to the mRNA so that it can't make the protein. So it can't make the abnormal protein. The abnormal protein can't build up. And then, in theory, it reduces the symptoms related to ALS. However, once again, even this medication, it's not a cure. It doesn't reverse any symptoms. It just slows down progression. So there's a 52-week study that showed slowed progression in ALS FRS scores, vital capacity, and grip strength. When they looked at the ALS FRS scores at 28 weeks, there was no change, but when they went out to 52 weeks, the treated group compared to the placebo had a definite effect. This was most pronounced in patients who were on the medication for a longer period of time, so goes along with most of these medications that there does seem to be a benefit if they are started earlier in the course. So in terms of tofersen dosing and side effects, so tofersen is what's called an intrathecal medication. So basically it has to be injected into the cerebral spinal fluid. So this is usually done by a lumbar puncture or a spinal tap. And then the medication is given over 1 to 3 minutes. So it does require an additional procedure, and has to be done in some kind of like office or outpatient setting. This isn't something you can do at home. The dosing is 100 milligrams or 15 mLs every 14 days for the first 3 doses, and then it's every 28 days. The most common side effects are pain at the site of the injection, headache, fatigue, and arthralgias, joint pain, though admittedly the injection site pain and the headaches could just be related to the spinal tap itself. There can sometimes be some rare but very serious side effects, such as myelitis or spinal cord inflammation, radiculitis, which is inflammation of a nerve root, aseptic meningitis, which is inflammation of the coverings of the brain, and then elevated intracranial pressure, which is high pressure in the spinal fluid. Those are rare, but they can happen. So the last essentially overall treatment I'm going to talk about is methylcobalamin or B12. Now this is an off-label treatment. It's not specifically approved for ALS. There was a phase 3 study that showed that patients with early stage ALS who received high dose methylcobalamin of 50 milligrams intramuscular injections twice weekly for 16 weeks had slower functional decline than those who received placebo. The ALS FRS score at week 16 was almost 2 points greater with the methylcobalamin than placebo. So there may be a beneficial effect if it's early in the disease course, but more studies and larger studies need to be done to confirm if this is really an appropriate treatment. Although overall, I would say, the risks of B12 injections are generally pretty low. Now, this does not necessarily mean you go out and get a B complex vitamin, because B complex has a lot of other vitamins in it that is not necessarily indicated. And this study was actually only for intramuscular injections, not for oral B12. So symptomatic treatments. So these are treatments that are used for specific symptoms. There's a lot of different medications that can be used, and you have to, when you're adding in additional medications, you do have to be careful about interactions between them. These need to be discussed with your neurologist, the multidisciplinary team, because some of these have non-medication options for treating the symptoms also. So the first thing I'm going to talk about is fatigue. This is a very common symptom with multiple potential causes. Can be coming from weakness, from hypoventilation, not getting enough air and oxygen in, or air hunger, and from as a side effect of other medications. So if you think if the fatigue is thought to be due to a medication, then the first thing to do would be to stop that medication. As I said, that can be a side effect with riluzole. So, doing a trial off of it to see if the fatigue improves is certainly a consideration. You can do short courses of steroids, but there's a limit to how much you want to do steroids, because in the long term, steroids have significant effects. A lot of people would probably know if they've taken steroids before. Most people do feel better on steroids. It's not necessarily due to like a specific effect, even if somebody doesn't have like a specific disease condition. As I said, even most normal people will temporarily feel better on steroids. So as I said, if there's a specific, issue or short-term issue, steroids can be an option, but this is definitely not a good long-term option. Modafinil is a medication that is used in fatigue and narcolepsy, but it has also been used for fatigue and other conditions. It's an off-label use, but it is a consideration if the fatigue is very debilitating. And the other thing to consider is if the fatigue is due to things like weakness and air hunger, like things that like therapy may be helpful, or considering like oxygen, non-invasive ventilation may also be other options that can help with the fatigue that don't necessarily involve medications. Muscle spasms or twitching. This is a very common symptom in ALS. The primary medication that can help with this is a medication called mixilotine, and it's given 150 milligrams twice a day. And in a study with 20 patients with ALS and cramps, the patients had a reduction of 2 cramps per day when they had a baseline of 6 per day. So they go down to 4 with no serious adverse effects. This was only done over 2 weeks. The issue with mixilotine is the side effects, is that a lot of people do experience side effects, especially when you're on it for a longer period of time. This can include dizziness, nausea, tremors, falls. So it is certainly a reasonable medication to try. It does help with cramps and muscle twitching, but you have to watch really closely for side effects from it. And it is not uncommon that it has to be stopped just due to the side effects. Other, excuse me, other medications that have shown some efficacy, but no really good evidence behind it is levetiracetam or Keppra, carbamazepine, and phenytoin. So these are all actually anti-seizure medications. Levetiracetam in general doesn't have a lot of side effects, except for sedation and sometimes some psychiatric side effects. But as I said, uncertain how much it truly works. With carbamazepine, if that is an option that to be considered, that the sodium levels need to be monitored because it can actually reduce the sodium levels in the blood. Quinine sulfate actually is a good medication for cramps and twitching. However, it was banned in the US because of a significant problem with cardiac side effects. However, a small amount of quinine is found in tonic water. So sometimes drinking tonic water, if that is an option, or giving tonic water can help with cramps. However, there is a somewhat large proportion of the population who has some allergy to quinine, usually a rash associated with it, sometimes severe nausea. So that is something to watch out for, even with the use of tonic water. Thick mucus. So thick mucus is another symptom that can occur frequently, and it can occur with or without sialorrhea or increased salivation. I'm going to talk more about the sialorrhea in a few minutes. This can be associated with increased secretions. And also you want to make sure that the increased salivation is not being overtreated, because sometimes that can lead to a feeling of thick mucus in the back of the throat. So some simple things that can sometimes help is increasing fluid intake, because this is more common with dehydration, and using higher humidity air, so humidifiers can be helpful. So a medication that can help with this is acetylcysteine. So this can be given 2 ways. It can be given via a nebulizer, over a face or over a trach, and this is given as 3 to 5 mLs of a 20% solution, or 6 to 10 mLs of a 10% solution every 8 to 12 hours. This is also available orally. The orally is a little more complicated. So it's a liquid formulation, so you actually can also give it through a peg tube. So basically you use the nebulizer 10% solution vials, or the 20% solution vials, and you give 200 to 400 milligrams 3 times a day. The complicated part of this is that you need a needle and syringe to draw out the liquid. And then you use the syringe to put it in the mouth or through a peg tube. It is also does not necessarily taste good. So sometimes actually the recommendation is to put it into soda and then drink it that way. And that's better tolerated in terms of taste. Additionally, for thick mucus, cough assist device and suctioning can be helpful in kind of bringing that up and bringing it out, because some of it has to do with a decreased ability to cough. And so that allows the secretions to pool in the back of the mouth and throat. So sialorrhea, or increased salivation, is also very common. So drooling. It's a very common symptom. It's usually due to a combination of facial muscle weakness and reduced ability to swallow. So there are a lot of treatments actually for the drooling. The main limitation of all of them is it tends to be side effects. So atropine can be used as drops that you give every 4 to 6 hours. It does generally work pretty well. The issue is that since it has to be given very often, that can be a little hard to do. Another option is scopolamine patches that are replaced every 72 hours. However, a lot of people have problems with dizziness dizziness and sleepiness is a common side effect with scopolamine. The other thing is that sometimes in some people, scopolamine can make them too dry, and then you might start to have problems with the thick mucus. So even though it says you're not supposed to cut the scopolamine patches, you can cut them and try a half a patch and see if that is tolerated better. Glycopyrrolate is another medication that is often used. It's a 1 milligram tablet 3 times a day. Amitriptyline can be a good option. So amitriptyline is actually a medication that it's an antidepressant, but at lower doses, it's often used for things like nerve pain and headaches. However, what you're using it for in this situation is you're actually using a very common side effect of amitriptyline, which is dry mouth. And so this can be given at bedtime. Common side effect is sleepiness, so that's why it's recommended to be given at bedtime, but that may be a good option for somebody that is having a lot of drooling and also having trouble sleeping. Another medication is hyoscyamine, which is available in a sustained release formulation that only needs to be dosed twice a day. A short-acting formulation that has to be given every 4 hours, and then also a patch that is used similar to the way that scopolamine is used, that is replaced every 3 days. Now, if the medications are not tolerated or they're not working enough, the next consideration would be botulinum toxin injections, or Botox. So basically, this is an injection directly into the salivary glands on usually the sides of the face. And the number of injections can vary depending on how much is being given and, what is the situation with the drooling. So dosing can vary anywhere from 40 to 100 units, or sometimes I've even used more than that. So generally, it's starting off with 1 or 2 injections kind of on the side of the cheek. Sometimes another injection under the chin is added. The main side effect and concern with using the Botox is that Botox essentially weakens muscle. So it can spread out of the areas where it's injected and cause problems with dysphagia, trouble swallowing, weakness of facial muscles, or respiratory issues. That is not common, but it is possible. And in somebody that already has issues with those, it's certainly more of a concern and something that has to be considered if the botulinum toxin is going to be used. The other issue with it is that the injections have to be repeated. So typically the botulinum toxin lasts anywhere from 2 to 3 months and then starts wearing off. and the injections have to be repeated about every 3 months. Usually most insurances, including Medicare, will not approve the injections to be done sooner than 90 days. So another symptom that is also happens and can be distressing is what's called pseudobulbar affect. So basically, this is emotional lability, where you get excessive laughing or crying, or you get those symptoms in inappropriate situations where you wouldn't normally be laughing or crying. There is a medication approved for this called dextromethorphan, quinidine, or Nuedexta. The main issue with this is it is generally difficult to get approved. And the medication is given twice daily, initially daily for 7 days, and then twice daily. Other options for the symptom include other antidepressants, such as amitriptyline or nortriptyline, which we talked about amitriptyline previously. Nortriptyline is another similar medication. And then other antidepressants that are more commonly used that are in the SSRI group, with fluvoxamine being one in particular for pseudobulbar affect. Spasticity. So spasticity is a very common symptom in ALS and can affect people to varying degrees. So there are multiple options for treatment for spasticity. Baclofen or tizanidine are muscle relaxers that are very commonly used for this. And overall efficacy between the two is similar. Baclofen is typically dosed anywhere from 5 to 20 milligrams 2 to 4 times a day, with usually a maximum around 80 to maybe 100 milligrams daily. Side effects are most typically weakness and fatigue. And the weakness is not necessarily increasing the weakness. It's more of when you start reducing the spasticity and there's weakness along in the same muscle that is spastic, sometimes that weakness then becomes more apparent when you're reducing that stiffness that's in that muscle that may have been kind of protecting someone from noticing all of the weakness that is there. Tizanidine is another option, usually dosed 2 to 4 milligrams daily, 2 to 4 times a day. Side effects include dry mouth. Tizanidine can cause elevations in LFTs, so it may be something that needs to be watched a little closer in patients that are on Liluzol, and fatigue. Now, if the medications don't work, or side effects, you just can't tolerate either higher doses or tolerate it at all due to side effects, another option is botulinum toxin injections. However, as we talked about before, basically it can weaken muscle, and the theory behind it working in spasticity is basically overactivity of the muscle. And so if you reduce some of that overactivity so it's not so stiff, you can make the muscle work better. But as I said, one of the side effects is potentially making the muscle weak. If that muscle that is spastic is also weak, then you may be making that even worse. Also, botulinum toxin injections can spread to nearby muscles, so you can cause weakness in other muscles that are not injected. So it certainly has to be done with care and thought to the goals of using the medication. So a common situation where it's used is, if there's pain, or if it would help with care. And those situations are, we have a specific goal in mind that we're trying to use the botulinum toxin injections for, and it can be very effective in those situations. So other options for spasticity are baclofen pumps, which is useful with severe spasticity, especially in the legs, but this requires an outpatient surgical procedure for placement and is not typically done for ALS. Cannabinoids, cannabis could be another option, but there's ongoing trials right now to see if that is. So pain is a really also another common symptom. It's usually multifactorial due to things like reduced mobility, muscle spasms and cramps, spasticity, the muscle stiffness, and other issues that may have been pre-existing, such as back pain and joint pain. The reduced mobility due to ALS can also cause musculoskeletal pain and then pressure-induced skin injuries and ulcers. So things like nursing care is very important to change positions frequently, and things like specialized mattresses, pillows can help when people are in bed, and custom fitted wheelchairs with like tilt function and that can change position are also really important for ALS patients. Analgesics and anti-inflammatory drugs like NSAIDs, over-the-counter medications, some prescription anti-inflammatory medications can be helpful for specifically treatment of pain, physical therapy. Opioids would be considered a last line, especially as those can also affect breathing. So, this is something to bring up if you're having problems with pain with the neurologist, with your multidisciplinary team, because there may be options for helping. Sleep. Sleep is a common symptom also, and this is also additionally multifactorial. So it's not always directly the issues with ALS that can contribute to sleep problems. And a lot of people have pre-existing sleep problems. So things like anxiety and depression can contribute to sleep issues, dysphagia, difficulty swallowing, dyspnea and shortness of breath, and inability to change position in bed. That can lead to some sleep issues, and the muscle cramps and twitching, which a lot of times people do feel worse at night. Things like non-invasive ventilation can help. But you have to be careful with sleep medications because medications that cause sedation, which most of the sleep medications can worsen shortness of breath. And there's been no trials that have evaluated typical sleep medications in ALS. So some options that we sometimes use for sleep, but as I said, none of these have been specifically studied in ALS patients, are amitriptyline, mirtazapine, chloral hydrate, diphenhydramine, zolpidem, and flurazepam. So that comes to the end of my discussion of medications and treatments in ALS. Thank you so much for having me, and I'm happy to answer any questions.
Wow, thank you for that clear and concise outline. That was wonderful. There are several questions. There are actually a few questions regarding vitamin B12. And one of them is, when you say early intervention is best, how early is early?
I mean, I think for all of the medications that we use for progression, I mean, starting some of them as soon as, diagnosis. Now, I think the other thing is that you don't necessarily want to be starting all of the medications all at once. So it's probably best to take a little bit of, at least a couple weeks or a month on one, then start the next, then start the next. Just because then you'll know better if there's side effects with a particular medication or if there's going to be any interactions between them. But that's something to discuss, order of starting with your neurologist and your multidisciplinary team.
Thank you. And also with regard to B12, is there an oral equivalent that's effective?
So B12 is available orally, but that is not something that I'm aware of has been specifically studied. So, the only studies have been done with the intramuscular injection form of it, so I can't say if the oral is equivalent to it.
Okay, thank you. There's also a question about how does Nudexa work? What is the mechanism of action?
That's a good question. I don't know. Unfortunately, like a lot of medications that we use for a lot of conditions, including ALS, we don't always know how they work. We know they do work, but the why is actually a very difficult question for a lot of medications.
Fair enough. Um, there's also a few questions about Radicava. And one of them is about how to get it. Is it covered by Medicare and Medicaid? And is there a way to get it through Medicare without paying tens of thousands of dollars every month? So, any thoughts about that?
Yeah, as far as I know, it should definitely be covered by Medicare. I mean, I guess, in terms of specific plan, it would matter on what specific type of Medicare that you have in terms of cost. But I definitely know that the company has, they may have options where they can provide additional support if you have a particularly high copay for it. So, the best option would probably be to contact the company directly and see if they can provide any help. In your clinic, if you're being seen in a multidisciplinary clinic, they may also be able to help with that.
Yeah, you're right. JourneyMate, which is the company that that is used, they oftentimes can steer you toward grants that are available. So that's great. Um, Another question about the Radicava is if it's best when early in diagnosis, does it make sense to stop it when you're 2 or 3 years out after your diagnosis?
Yeah, I mean, that's a good question. Um, I think, for all of these medications, since we don't necessarily know, especially in later courses, how, if they're working, if I always tell patients, if it's hard for you to take, if you think it's causing side effects, the what we know about how the benefit of it is, if it's anything, it's small. So if you're having too many side effects or it's getting too hard for you to take, then, I don't have a problem telling people just stop it if it's easier for you, because, it's not worth causing extra stress in your life over something that's probably not going to have a strong benefit at that point.
Thank you. Um, any thoughts about the use of Cipro and Celebrex in ALS?
Yep. So I had a patient asking me about that earlier this week. I think, for any medications that are undergoing trials right now, I would not try to be using them outside of a clinical trial, because, as I said, we don't know how they work. And as I said, in, a lot of these medications that showed some promise in like a smaller phase 2 trial, it didn't pan out in the big trial. Relyvrio being the example for that, the big, big example, recent example for that. In that, until we have more information, I don't recommend using medications outside of a clinical trial. And something like, Cipro, it's an antibiotic. There can be some significant issues with taking antibiotics on a long-term basis. So it shouldn't be something you try to do on your own.
Thank you. The original Riluzole studies projected that it extends life by about 3 months. Has the data changed on that? And is it thought to extend life longer, perhaps?
Not that we know of at this point. There haven't been any further studies, and in all honesty, most studies going forward are likely to be on the small side, because once a medication is approved, those very large trials are often not done again.
Right. Another question that has come in says that riluzole and radicava are recommended for almost all ALS patients. Do you think they're safe enough to really recommend to your family member? They cause so many side effects.
Yeah, I mean, I think in general, in general for both medications, I think the side effects tend to be mild, and that's why, we monitor, and if people are having side effects, then we stop it. And I mentioned some of the very severe side effects, but those are very, very rare. I can't even think of that I've really seen any of those. But as I said, they're things that have to be mentioned. But we do recommend them for every patient, because we do think there is at least some modest benefit.
Thank you. Another question. Are there any therapies coming down the pike that you consider to be promising or exciting?
Once again, a hard question, because as I said, there's been a lot of medications that have seemed promising early on, and then it turned out that they weren't. So, I kind of have developed a caution of, I need to see the results of those big trials before I'm going to believe anything actually works.
Understood. Understood. Thank you. Also, are there any alternative or off-label therapies that you consider to be worthwhile?
Uh, as I said, right now, I think not that we know of. Anything that I talked about are the ones that, there might be some promise to, is that, you always have to be careful with medications that are not necessarily like FDA approved, like supplements and things like that, because you don't always know what you're getting. And there's a lot of things out there that that people may be saying that work, but I don't know that we have good information for that, and there can be harms. And if you are going to take any, of those like supplements or anything like that, you need to discuss it with your medical team and your neurologist, because there can be interactions with medications.
Thank you. They keep coming. So, um, let's see. Any thoughts about detox procedures?
There I mean, detox has not been shown to be helpful for any specific condition that I am aware of. So no, I would definitely not recommend that.
And what is your opinion about taking TUDCA by itself?
Taking what? I'm sorry, what?
Oh, TUDCA, the um taururside, the half of the Relyvrio,
Oh, um,
Iodol.
I mean, I don't know that I have an opinion on that. I mean, the medication was not shown to be effective, so it's not likely that a component of it is going to be effective.
Thank you. Another person asked if you can get Botox without a feeding tube. I think she's referring to um, the possible causing of weakness.
Oh, yeah, absolutely. So, Botox, I do Botox injections on people with spasticity all the time. It's just, as I said, you have to plan, and you have to do it carefully with, an understanding of what the effects are and what to watch out for in terms of the side effects.
I think we've come to the end of our questions,
Okay.
which was a lot. Wow. But really, we want to thank you so much, Dr. Manning, for it was really a very comprehensive summary of what's out there. We thank you so much for outlining all this for us today. And so in conclusion for this session, I wanted to invite you back at 2 o'clock. We have breakout sessions, one on VA services, benefits for people with ALS, and one for understanding FTD when there's an FTD ALS diagnosis. So thank you again, Dr. Manning.
Yep.
We
Thank you so
appreciate you.
much for having me.
Thank you.
Okay, bye.